we're going to be looking at the vascular system. Now, a quick reminder, arterial and venous disease are two separate diseases. They can occur simultaneously, but for the purpose of this discussion, they are two separate entities. The first concept we have to understand is the concept of a chronic venous insufficiency. In chronic venous insufficiency, as with everything else in medicine, we begin with the history. When we come to the history of chronic venous insufficiency, it is important to get an overall view of your patient, including age, race, gender, where the patient comes from, and social history. But during this presentation, we are going to be focusing only on the history that is specific to chronic venous insufficiency. If we look at the etiology of chronic venous insufficiency, we look at venous obstruction, venous reflux, failure of the calf pump mechanism. Why have I jumped to etiology? The reason is that the etiology can often be determined on a good history of the patient. So, for example, in venous obstruction, has the patient had any DVTs? Venous reflux means the valves don't work, as on the example on the right, that the blood flows backwards. This can be determined by a patient who's had previous injury, such as a clot that has now dissolved, or failure of the calf pump mechanism. That would be, for example, a patient who is paralyzed. If we look at a history, these are questions that we must ask in a chronic venous insufficiency patient. Have they had previous or do they have present ulcerations? The duration, how long did they have them for? How long did it take to heal? And what did they do to get them to heal? Have they had any previous thrombotic episodes? Have they had previous DVTs? Were they treated? How were they treated? How were they diagnosed? And where in the vessels were they? Previous venous and non-venous surgery to the leg, pelvis, and abdomen is important to determine. So, for example, a patient that has had a Trendelenburg stripping. This is surgery that was used to treat a superficial varicose vein for cosmetic reasons. This was usually done in a patient's younger youth, and now in that patient's old age has become a problem with chronic venous insufficiency. A patient may, for example, have had pelvic surgery, for example, an ovarian carcinoma with radiation. This can damage the vessels and is important to determine, as can help you with the etiology. Have they had any abdominal surgery with destruction of veins or lymphatics? The other thing to determine is, has this patient ever been treated before or had any therapies for this problem? Have they worked? How did they work? Was the patient compliant? If they were not compliant, why was the patient not compliant? So, for example, elastic compression stockings may be too tight or too uncomfortable, too hot for the patient to wear. These are all important to determine so that a tailor-made plan can be made for that specific patient. The other thing that is important to determine is whether the patient has got any arterial problems. The reason for that is that this could then impact on our ability to treat the patient for the chronic venous insufficiency. For example, a patient may not be able to wear tight compression stockings because their blood supply to the limb is compromised from the arterial point of view. Please remember though, arterial disease and venous disease are still separate entities. They can cross-occur or simultaneously occur in a patient, but they're still separate entities. But the one can impact on the other one's ability to be treated. If we look at other questions that must be asked, has this patient got any diabetes, mellitus? This can impact both in terms of the infective risk to that ulcer, the ability for the wounds to heal, and how the patient responds to treatment. So, for example, a patient might have a peripheral neuropathy secondary to the diabetes. Autoimmune diseases are important to determine. You may ask why, and it's a very simple answer. These patients are often on immunosuppressive drugs such as corticosteroids, methotrexate, etc., and these impact on your ability to heal and therefore the ability for ulcers to heal in the lower limb in chronic venous insufficiency. As we stated earlier, a calf pump failure can lead to one of your problems. So locomotive problems, the patient's ability to walk or to pump the calf, can have an impact in chronic venous insufficiency. The next one is, has a patient got any other medical conditions that could impact on treatment? Are they under any chronic medication? For example, chemotherapy has an impact on ability to wounds to heal, even if the disease or the cancer is in a completely different part of the body. Is the patient taking any current medications not already mentioned? And is the patient allergic to anything? The reason why this is important is a lot of dressings these days contain many different products. And by placing something on a patient that the patient is allergic to, we can actually aggravate the current problem. Now we come to the examination.
Like in every local examination, we do inspection, palpation, percussion, and auscultation. With inspection, we look at the position of the veins and note them on our patient records, and we record the site and the extent and the size of the veins. We also look at the skin for any skin changes. With palpation, we palpate the texture of the subcutaneous tissue on the skin, and we feel if there are any defects in the deep fascia which may indicate perforators. We also look for pitting edema above the ankles, because that might be an early sign of venous insufficiency. Then we do percussion to test if there is any conduction of the fluid thrill past the veins. So that can be an indication that the valves of the veins are incompetent. With auscultation, we listen over the bunch of varicosities to hear if there is a murmur which may be indicative of arteriovenous fistulae. There must be remembered that a general investigation is very, very important, because the underlying cause of the varicose veins might be in the abdomen. For instance, there might be an abdominal tumor or a tumor in the pelvis that might be felt with vaginal or rectal examination.
If we look at ulcers, at the end of this part, we should be able to answer these 7 questions. They're important to determine, as it can help us with the treatment and the management of these patients. We are now going to look at each one of these individually and why they're important and how we determine them. Anatomical site. Where is it on the body? This is important for a number of reasons. 1, for documentation and legal purposes. We must document whether it is the left or the right limb. It is also important that if another doctor sees this patient, they're able to see what did you say and what did you see at that time, so that they can continue the management and treatment of this patient. What part of the body was it on? Is it on the leg, trunk, arm, etc.? It is also important to state whether it is anterior or posterior, medial or lateral. Size. Size is important, and you may ask, why is size important? We know larger wounds or ulcers consume more energy and have more of a physiological impact on the patient. Secondly, size needs to be determined so that in future examinations we are able to state whether the ulcer got smaller, whether it got larger, or whether it remained the same. And this helps us to determine whether our treatment is effective or not effective. The shape is important. This needs to be clearly documented. The best way to document shape of an ulcer is to take a transparency and actually trace out the shape and file that transparency. This would help you to then determine and follow up what is happening with this wound. If we look at the surface or the base, we need to determine whether it is infected, whether it's granulating, whether it is septic. This has all got implications in terms of treatment. Do we need to add an antibiotic? Do we need to change our dressing to something more effective? Or if it's granulating, we're doing a great job, we must just continue with it. If we look at the depth, is it onto other structures, for example, bones and tendons? This would impact on future abilities and whether the patient needs to go to theatre to have it cleaned. How deep is it? This can be monitored and can help us to determine whether this wound is infected, not infected, healing, becoming more superficial, or getting deeper. The color of the wound and the surrounding tissue is important. A color of a wound can help us in many ways. So, for example, certain colors can indicate certain microorganisms are involved in the wound, or the blood supply is good to that area, or that the wound is healing. If we look at the edge, please refer to Browse for this, as it is beautifully described in Browse. But a sloping, a punched out, undermined, rolled, or everted edge can all indicate to us possible pathologies, indicate to us whether the wound is healing, indicate to us whether the wound is not healing, and how we can better manage this patient. So for example, if we look at this leg, if we look at the first thing we must determine is, where is this wound? This is on the right leg, the lower third, the medial aspect of the leg. We can also see clearly in this photograph that the surrounding tissue is darker than his natural skin color. This is called lipodermal and is one of the clinical signs of chronic venous insufficiency. Chronic venous insufficiency and the tourniquet tests. These are important tests to determine and will be demonstrated in the video that follows. It is important at the end of tourniquet tests that you not only know how to do it, but why you do it, and what is the role of each test, and what is the clinical application of these tests. Please watch the video for a clear demonstration on how to do these tests.
Now we're going to demonstrate to you the tourniquet tests that we do on a patient. All we need is 2 tourniquets, rubber band or rubber tubes like this, that we are going to use for our tourniquet tests. Now first of all, we let the patient stand up and all the veins fill up in the leg, the superficial veins. Now we put this tourniquet around the upper leg, just below the groin, and with this, in this way we obliterate the greater saphenous vein. And we put this one around, just below the knee, to obliterate the lesser saphenous vein. There we are. Now, the greater saphenous vein has been obliterated, and the lesser saphenous vein has been obliterated, and the veins are still full in the leg. Now we ask the patient to lie down. And we now expect that if we lift his leg, that the veins will empty, because we expect that they will drain through the perforating veins into the deep veins and then empty. If they do not empty like that, then we must deduct from it that there's a great suspicion that the deep veins are blocked or are closed. Now our next test is going to be to release the tourniquets, and we make sure that all the veins are empty, like that. Now we put a tourniquet on the same spot, just below the groin, to obliterate the greater saphenous vein, and we put our tourniquet below the knee to obliterate the lesser saphenous vein. There we are. Now we've got no veins visible, and we've got the 2 good tourniquets in position. Now we ask our patient to stand up, and we watch here. If there are any veins filling up immediately here, then we know that there must be incompetent perforating veins. If nothing fills up, then we release the lower tourniquet, and if it fills up now, then we know it must be an incompetent lesser saphenous vein which enters into the popliteal vein. If nothing fills up and we release the tourniquet around the thigh and we now see the veins filling up, then we know that it must be an incompetent greater saphenous vein. Now today we're going to demonstrate the tourniquet tests on a patient that has got varicose veins. Now first of all, we let the patient stand straight up like this and we inspect the leg. Here we can see the varicose veins running in the distribution of the greater saphenous vein, and we can see the lower foot above the medial malleolus. Here we can see the typical pigmentation of the skin as a result of chronic venous insufficiency. Now we're going to do the first tourniquet test to decide whether the deep veins are open or not. And first of all, we put a tourniquet along on the upper leg, just below the groin, to make sure that occlude the greater saphenous vein, and now we put a tourniquet below the knee to make sure that the lesser saphenous vein is occluded. Now, if you ask the patient to lift the leg now, if the vein is empty, the blood must be going through the deep venous system, through the perforators, through the deep venous system. Right, kom ons laat ons nou, let's lie down now. Now if we lift the leg up, you can see that the veins still remain full. They are still prominent. Now we loosen the tourniquet here. We still see prominent veins. So we must deduct from that the deep venous system must be occluded. Now if we let go the tourniquets, we see that the veins run empty. So they can empty through the superficial system, but they don't empty quickly through the deep system alone. Now we're going to continue with our tourniquet test. We make sure that all the veins are empty, and we put the tourniquet below the thigh to occlude the greater saphenous vein. Now we put the tourniquet below the knee to occlude the lesser saphenous vein. Now we're going to ask our patient to stand. And if we ask the patient to stand and there's suddenly a filling up of veins here, then we must know that they fill up from the incompetent perforators. But if there's no filling, then we know that the perforators are not incompetent. Right? Let's stand up for a moment. Now we can see there's no filling of the superficial vein. And we loosen the tourniquet, still we see no filling. Now I want you to notice nicely, if we remove the upper tourniquet, we can see that the veins fill up from above downwards. And from this, we can then deduct that the superficial, the greater saphenous vein is incompetent.